Hi everyone, this is Dr. Sharad Jaitly from New York, your cardiologist on MuniMeterHealth.com. Thank you for watching, learning, and sharing, my friends, on MuniMeterHealth.com, on Facebook and YouTube channels. I appreciate this so much, specifically so because you're taking such great interest enthusiastically in learning about the human heart and its illnesses. So again, thank you so much for spreading my cause and educating freely to all. In today's video vignette, very shortly, I'd like to discuss a pretty intense subject, if you will, specifically so for the medical students, residents, and trainees, the fellows, and of course my colleagues who want to brush up their, aspects of cardiopulmonary testing. That's what we're going to talk about here. What is cardiopulmonary exercise testing? It's also called CPET. It's a very, very old test, but then has been revived lately because of the increasing interest, specifically so because people are starting to use this more so for evaluating preoperatively in certain settings, specifically so for the cardiac transplants and or prior to lung resections. Being a chest specialist as well, because I'm a fellow, I've been a fellow at the American College of Chest Physicians in addition to the American College of Cardiology. I've felt that I think the heart and lungs, as you see, they should be taken as one unit more or less within the chest because, obviously we need the two sets of lungs around the heart to make sure the oxygenation is going well in order that the heart can function also very well. So it is a cardiopulmonary test, if you will, and it speaks of various settings, including a gaseous exchange that's being analyzed during the time when the person is on the treadmill. Now, you can perform this test on a bicycle or on a programmed ergometry, the upper arm ergometry, if the patient is not able to walk for any reasons. So preoperatively, it's a wonderful test, specifically so if the person is going for cardiac transplant evaluations, etc. Lung resection. Likewise, also great to know that exertional dyspneas when patients are presenting with shortness of breath on exercise, upon walking, etc. The cause needs to be elicited. I think it's a good idea to have this cardiopulmonary test done. Now, classically, it's performed where the person is actually walking on a treadmill and is hooked up with the routine EKGs, just like a regular treadmill stress test. In addition, what we are also doing is pulse oximetry, and then, of course, also measuring the gaseous exchange that's occurring during the time when the person is exercising. Now, the protocols may slightly differ because one tends to use a more gradual exercise rather than the Bruce protocol that we are quote-unquote used to in our settings of cardio stress test. So in a cardiopulmonary stress testing, one uses a gradual ramp up protocol where every minute it tends to change its speed, and that could be specified in at the end of your summary when you're writing the report. Now, what parameters would you like to see, obviously? Now, basically, one likes to see the PVO2, which is, in other words, an aerobic capacity that the person has, and that needs to be sort of also seen as a marker, if you will. Now, anything less than 14 ml, which is normally a standard cutoff by the ACC and ACP, that people are starting to say that aerobic capacity is diminished. In that setting, like specifically so if somebody's going for a cardiac transplant, you want to see an aerobic capacity of less than 14 ml because that signifies that the heart failure has a poor prognosis and therefore these patients are ready to go for cardiac transplant. So in general, 14 to 17 is the normal range, and anything more than 17 that shows you that things are going well and right now patient may not be a good candidate for transplant as yet. So that's one. The other thing that you like to see is the VCO2 and a VO2 ratio, and that speaks of a metabolism here. Now, essentially, it's a reflecting substrate metabolism. Normal is less than 0.8, and it progressively increases during exercise. We know that. Anything more than 1.1 signifies physiologically maximal response, but lower values will suggest only a submaximal report. So, one has to be cognizant about this parameter as well. A third parameter that commonly is looked at is VCO2 slope. And here you're talking about the ventilatory efficiency, basically. How often, how good is the cardiac carbon dioxide output in addition to the ventilatory volume. So it's reflective of it's reflecting ventilatory efficiency, if you will. And normally the values are 34 and above will indicate a significant cardiopulmonary disease like a heart failure, etc. So lower values are better, but higher values will say that the slope is extremely suggestive of cardiopulmonary disease. So higher values, worse prognosis. Just remember that on this one, okay? End-tidal PCO2, it is just a manifestation of perfusion. In other words, a manifestation of CO2 diffusion. So it is end-tidal PCO2 is a good parameter to follow, and it reflects perfusion. So better cardiac output and a better CO2 diffusion. So higher values indicate that the CO2 is being moved out, and lower values are showing a bad prognosis. So lower values, poor prognosis in this setting. Just remember, end-tidal PCO2, lower values, poor prognosis. Next is O2 pulse. What is oxygen pulse? Now, oxygen pulse is really a reflection of a stroke volume here, and basically tells you that it's a surrogate of how much oxygen is being delivered per heartbeat. So obviously you need to check the heart rate on the EKG here, and so it is factored in. The heart rate is factored in. The stroke volume is the amount of oxygen that is being delivered per. So it is in fact also a factor of your cardiac output. The lower the cardiac output, the lesser will be the stroke volume, therefore lesser will be the O2 pulse, oxygen pulse being delivered. Heart rate recovery is at the end of 1 minute after the patient is fully maximized, when the test is being stopped or terminated. At that point, within 1 minute, if the heartbeats go down by more than 12 beats per minute, that is normal. But if it is not dropping that fast, that speaks of deconditioning or heart failure as well. Heart rate reserve implies that how much was the heart rate that was increased from the baseline heart rate. And if it is more than 60%, you're okay. But if it is less than 60%, that shows a negative chronotropic response or a submaximal response. That means the test patient did not exercise fully. So it may be a submaximal or non-diagnostic test, if you will, or even a negative chronotropy response, where then other electrophysiological studies for the heart rate response may have to be seen while the heart rate is not increasing in an individual who is exercising. Okay, other than of course beta blockers, but beta blockers should be taken into account here when you're assessing the heart rate reserve. VO2 work slope is essentially what you're looking at when an oxygen uptake per unit of work is being analyzed. That means how many watts of work did the person spend per minute, and what was the oxygen uptake in that individual. A higher slope will reflect an anaerobic demand, an increased demand, like say in obese patients or hyperthyroid patients, and a low slope will reflect that maybe there was an increased anaerobic work, like in heart failure or ischemic heart disease. So again, low values will suggest ischemia, higher values will suggest increased demand, okay, like in obesity or hyperthyroidism. So in a nutshell, these parameters must be used. I know they are a little complicated, a little more intense, but for a layperson, I just have a following message that this is a wonderful test before somebody is going for surgery, especially a pre-cardiac transplant. It's a very simple test. The person gets to walk on a treadmill. You're hooked up to the EKG, obviously, just like a routine test. Plus, you also have a pulse oximetry going on your finger, and a couple of other testings where oxygen and CO2 baseline will be recorded, and your tidal volumes will be recorded like in a spirometry, a routine spirometry. Patients who have exertional dyspnea or upon walking when they get short of breath with an unclear reason, they could have this test. Patients who are going for mitral valve evaluation, specifically so they have hemodynamics like mitral regurgitation, you've been told you have a regurgitant valve, and when to operate, I think it's very important that the cardiologist or the chest physician really performs this test, because hemodynamics of mitral regurgitation can be seen very, very importantly. Now, in a nutshell, the test will be reflected in the following way. One, it could be non-specific like any other test, where test numbers were not so sufficiently diagnostic of either way, positive or negative. Secondly, obviously deconditioning, somebody who's deconditioned, who has not been exercising at all. will also be reflected here, where there will be low normal peak VO2 and in the absence of any other abnormal response. So no abnormality seen, but your peak VO2 never rose to a normal level. That shows you're highly deconditioned, specifically so in obese people or patients who have not exercised at all. They just go from elevators to ignition keys, I always call them. Um, um, Obesity patients, as I said, again, you have a VO2 work slope may be high, but then that will also be seen where you have increased peak VO2, less than predicted as well. Cardiac limitations, like specifically where you have electrocardiographic abnormality that starts to occur, that will be the first sign, like an ischemia, or the heart rate recovery is less than 12, where the heart rate does not recover rather quickly, like less than 12 beats, more than 12 beats, it should drop in the first minute after the peak maximum heart rate, unless the patient's on a beta blocker. So all these things are indicative of cardiac limitations. Pulmonary limitations, one can also classify this test under, and one can look at and say, look, there might be pre-screening spirometries, which could be abnormal. You could have abnormal flow volume loops, which I'm sure you'll be referred to into another video, which I'll probably do later on. And the peak peak exercise respiratory rate. It's called the peak RR here. It is peak RR. If that's more than 50, that also speaks that there's a severe pulmonary limitation because the person is now almost breathing one time per second. Muscular disease, yes, it's a good idea to evaluate some muscular disease, specifically in a setting where you have restrictive lung disease, like in a setting where you have systemic sclerosis, etc. It got cut off here, but I apologize for that shortening of the slide. But in any case, pre-bariatric surgery, like specifically obese, grossly obese patients going for pre-bariatric evaluation, they should undergo this testing. In any case, they must undergo through a treadmill stress test or cardiac evaluation anyway. So in a nutshell, cardiopulmonary exercise testing is an old test, but it's being now performed increasingly by most cardiologists and chest physicians as a preoperative measure. And it's very useful because it gives you all these parameters and gives you better insight as to what's going on with the heart and lungs. And so just for the sake of it, just remember 14 ml is the cutoff, which will be definitely on the boards for your heart failure evaluations prior for cardiac transplant. So 14 ml is the cutoff, less than 14 ml, send them for surgery. More than 14 ml, more than 14 to 17 ml, one should say that prognosis is not that bad yet in those individuals. So anyway, so this is in a nutshell where we have cardiopulmonary exercise testing for you in this short video. Hope you enjoyed. I know it's a little intense, but I did give some pearls and points for my non-medical community, I call it. So this way everybody gets something out of this. And hopefully, please don't forget to write any comments, questions, and suggestions. And feel free, and I personally will respond to each one of them. I try to respond them as promptly as possible on MuniMeterHealth.com. Thank you again for watching MuniMeterHealth.com. That's my website, which I've created mainly for education purposes, for medical community as well as for general community. Okay, thanks again, and see you again into my next video.